بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم بكل خير. سعادة وكيل الجامعة للدراسات العليا والبحث العلمي، سعادة عمداء الكليات وأعضاء هيئة التدريس والحضور الكريم وطلابنا الأعزاء، نرحب بكم في اليوم الثاني من مؤتمر السكتة الدماغية، والذي سيشمل على جلسات علمية عدة كما سبق في اليوم الأول في يوم أمس. وقبل البدء بالجلسات العلمية يتفضل الأستاذ الدكتور محمد الشهري لتكريم بعض من المكرمين الرعاة للمؤتمر وبعض المتحدثين وأصحاب الأوراق العلمية، فليتفضل مشكورا. المكرمين هم مختبرات ألفا، مركز سيفال، كلية العلوم الطبية التطبيقية، كلية الطب، كلية طب الأسنان، كلية التمريض، مركز التأهيل الطبي والأطراف الصناعية في جامعة المجمعة، والآن ننتقل لتكريم المتحدثين وأصحاب الأوراق العلمية، بداية في الدكتور هشام كومو من جامعة الملك عبد العزيز، دكتور أحمد ساحلي جامعة جازان، دكتور لبنى عبد المجيد جامعة الباحة، دكتور عبد العزيز الشريف جامعة الجوف، دكتور فتحية مرسال جامعة الحدود الشمالية، دكتور فادية العنزي جامعة الحدود الشمالية، دكتور مشاري العلي جامعة المجمعة، دكتور عبد العزيز المسلم جامعة المجمعة، دكتور لينا البلوي جامعة المجمعة، نشكر المكرمين ونشكر سعادة الوكيل أستاذ دكتور محمد شهري. شكرا دكتور. شكرا. والآن سنستكمل ما تم في اليوم الأول من جلسات علمية، ونحب تذكيركم بما تم طرحه في الجلسات العلمية في يوم أمس. الجلسة الأولى كانت عن تشخيص السكتة الدماغية والتطورات العلاجية، كما شملت الجلسة الثانية على مستجدات السكتة الدماغية وعلاجها. وكانت الجلسة الثالثة والأخيرة في يوم أمس تشمل التعافي وإعادة التأهيل بعد السكتة الدماغية. ونستأذن سعادتكم في بدء الجلسات العلمية لهذا اليوم، ونبدأ بالجلسة الأولى والتي هي بعنوان العناية بالفم للناجين من السكتة الدماغية. وستدير هذه الجلسة الدكتورة ريم المطيري، فلتتفضل مشكورة. وليتفضل المتحدثون في الجلسة: دكتور أسماء فادن، أستاذ دكتور هشام كومو.
Ladies and gentlemen, good morning. I'm honored to be the scientific chair for today's first scientific session. I'm pleased to have joined me one of the passionate and successful speakers in the field of dentistry. Our first guest speaker is a Professor Asma Fadin. She's a professor of oral medicine, College of Dentistry, King Saud University. She has been involved deeply with teaching, research, and administrative works for the last 25 years. She has published many scientific articles in respected journals and member in many international dental societies. Prof. Asma, the stage is yours.
السلام عليكم.
بسم الله الرحمن الرحيم. أولاً أحب أشكر جامعة المجمعة لدعوتنا، وثانياً أنا جداً فخورة إنه من أبنائنا وطالباتنا هم من الأسس اللي في جامعة المجمعة، وهذا جداً نشعر بالفخر فيه. بسم الله الرحمن الرحيم. We will talk today about the dental consideration and dental management of brain stroke patients. Okay, I am a professor of oral medicine and I'm a dentist. So why was I invited in the first place? Do I have a role in the conference like a brain stroke? Let's talk about this after this session. The editorial of Lancet once stated that any stroke is a terminal event, but a preventable stroke is a tragedy. So do we have to wait till the tragedy occurs, then we will take an action? Okay, we have talked yesterday, my colleagues, about the strokes, type of strokes. We have ischemic and the hemorrhagic strokes. So what's our role exactly? Our role can be explained by this diagram. Orodental health can affect the mouth cancer, diabetes, gum diseases, tooth loss, bad breath, dental decay, lung conditions, heart diseases, and stroke. This was taken from Shahryar in 2022. What exactly we're talking about? Let's talk about one of the causes or one of the risk factors that should take place in the risk factor list of the stroke. The association between oral periodontal status and the brain stroke. What is periodontitis? It is a chronic, it's a chronic multifactorial inflammatory disease of the supportive tissue of the teeth. Let's make sure that we have got the information about the inflammatory disease. Periodontitis, it results from a complex of interplay between chronic bacterial infection and inflammation as well. Periodontitis has been shown to include the systemic inflammatory response, which has been implicated in the atherosclerosis and CVD. So we can notice that the word inflammatory, chronic inflammatory, repeated itself. Also, periodontitis is associated with elevated markers of inflammation that are indicated in CVD and stroke risk. Tooth loss, a marker of past periodontal disease, has been related to subclinical atherosclerosis and carotid artery plaque prevalence. So there is an association between the chronic inflammation of the periodontal tissues and the stroke. Bacteria from the periodontal pockets can enter the bloodstream during daily activities such as eating, chewing, or toothbrushing as well. Periodontal pathogens were identified in carotid plaque. So there is an association and an evidence that the chronicity of the periodontal inflammation is highly associated with brain stroke. Oral health literacy has been defined by ADA that it is oral health literacy as the degree of which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate oral health decisions. What does it mean? Here we are talking about the link between stroke and orodontal status. I cannot see it. Concrete evidence confirming the association between oral inflammatory condition and stroke in large cohort prospective studies. Stratifying association between oral diseases, severity, and stroke risk and diseases effects on stroke survivor will be desirable. In terms of clinical pathology, a predictive model of stroke as a function of oral health status and biomarkers of systemic inflammation could be useful for both cardiologists and dentists. Here, this is the healthy gum. This is a very simple diagram showing a healthy gum, the accumulation of the bacteria causing accumulation of plaque, the formation of plaque, and causing inflammation. When it reaches to the bone and starting of the bone loss because of the plaque and the presence of the inflammation, it causes periodontitis and then a deep pocket, and the bacteria will enter the tissue surrounding the tooth itself. So this is the healthy gum, gingivitis, periodontitis, and advanced periodontitis. This is what we are talking about when it reaches the chronic inflammation. This is a simple picture of periodontitis, okay? And here a diagram showing oral status, the bacteria from the plaque, it can go to the systemic circulation or to the gut. If it goes to the systemic circulation, it goes to the heart and causing cardiac risks. This is a closer picture of the infiltration of the bacteria from the plaque through the gum or the gingiva to the vasculars inside the periodontal tissue, which goes to the digestive tract or the bloodstream, and the bloodstream is our concern here to relate it to the brain stroke. And then it causes rheumatoid arthritis, chronic obstruction, pulmonary disease, cancer, diabetes, and cardiovascular diseases. Birgitta, in 2015, he concluded that a statistically significant association between gingivitis and cerebral infarction. The findings emphasize the importance of maintaining proper daily oral hygiene to reduce the chronic inflammatory burden to the body, which in the worst case may lead to a catastrophic consequence such as stroke. Maybe oral health personnel should be joined to work together with general practitioners, nurses, and stroke specialists in awareness campaigning for preventing development of stroke. I've been here yesterday and watched the presentation given by my colleagues. And one of my colleagues, he mentioned the team for the stroke. And I would like, after this session, to include the oral health practitioner in the team. And we don't have to wait till the stroke happens, so we, as the oral health care practitioners, to intervene. We can start from the beginning by preventing and reducing the risk of stroke by taking care of the oral health of individuals. So, periodontal pathogens and cardiovascular diseases, according to Arabi, 4 different mechanisms could explain the link between oral diseases and cardiovascular diseases. First, an oral bacterium reaches the bloodstream following bacteremia to the blood. Second, during the process of an oral disease, mediators of inflammation are released and can enter the bloodstream. Third, following exposure to components of oral pathogens, pathogenic bacteria, an autoimmune reaction against host proteins take place. Finally, some oral pathogens produce toxins and with pro-atherogenic action. Here we can see the point of this session is that we can intervene before the stroke takes place by taking care of the oral health, so we can reduce the possibility by putting the oral health status of any individual in the high risk list. If it occurred, the stroke happened already, we can intervene as well, taking care to improve the quality of life of the individuals. So it is not an ever-ending story by having the stroke. We can intervene to improve the quality of life of the individuals. How to take care? By reducing cardiovascular risk by exercising, antimicrobial agents, probiotic, sleeping well, dietary, and oral hygiene, because it is one of the sources of the chronic inflammation that can affect the cardiovascular system. Based on in 2023, Li Shang, based on their study result, people with a stroke history had poor oral health-related quality of life. So the oral health starts before the stroke, continues during, and to follow up, because it is a source of infection, and also after it happens, the quality of life of the patient, we will talk about now, can be improved by taking care of the oral health. Lower health literacy and the activity daily living disability were associated with worse quality of health. Further studies are necessary to define practical strategies for reducing the risk of stroke and oral health with constantly lower health literacy, thereby improving the quality of life and providing health care of older people. What is known? Stroke, of which ischemic stroke particularly constitutes 87% of all events, stands as the second most prevalent cause of mortality globally. Oral health plays a crucial role in the process of stroke recovery, promote identification and targeted interventions for those exhibiting poor oral health, can potentially enhance their food consumption, curtail the incidence of pneumonia, and possibly expedite the overall recovery from stroke. 2022 showed concrete evidence confirming the association between oral inflammatory conditions and stroke in large cohort prospective studies, stratifying association between oral disease severity and stroke risk and disease effect on stroke survival will be desirable. In terms of clinical pathology, a predictive model of stroke as a function of oral health status and biomarkers of systemic inflammation could be useful for both cardiologists and dentists. So are we talking only about the periodontal disease? Is it the only source of infection or chronic inflammation in the mouth? We can include also the dental caries as a source of infection, tooth loss due to systemic diseases and chronic inflammation of the periodontal tissues, and endodontic lesions when you open the root canal as well. So we have to eliminate any source of infection from the beginning before proceeding with any dental procedure. This is an example of caries, tooth loss, and root canal treatment. So the bacteria can transfer to the bloodstream through many routes through the oral mucosa. Donders in 21 studied the association between the inflammatory burden of periodontitis and presence of extent of coronary calcification. They have concluded that periodontitis is associated to higher risk for cardiovascular morbidity and mortality, but it's not an independent risk factor. So it's one of the factors should be included in the stroke high risk. Considering the findings of this study and previous studies, it is still increasingly important to bridge the once wide gap between dentistry and general medicine to identify patients at risk for cardiovascular diseases in an earlier stage. This is the message I wanted to convey. So is it a causal or casual relationship? We don't know, but we have to break this circle by taking care of the oral health from the beginning. Risk factors, all these have been discussed yesterday. So my question is, can we add oral health status as a risk factor for brain stroke? And I think after all these evidences, the answer is yes. A comprehensive history and oral clinical examination performed by a dentist periodically can prevent and can diagnose high risks and early sign of stroke patients. Let's go through the dental management after the stroke happened, okay? What is our role as a dentist? Patient with a stroke in his record shall get special care during a dental treatment appointment. The choice for morning sessions or midday instead of early morning or late in the day. It should be short without any stress. Clinical approach shall take into consideration several aspects like disabled patients shall be helped by the nurse to sit on dental chair. Their airways shall be free and they shall be accompanied by person taking care of them, especially if special speech difficulties is involved. History taking shall be simple and optimistic. Dentists shall stand in front of the patient without mask, preferably, shall look him in the eyes, shall move slowly, and questions shall be simple and clear for plain answers, yes or no. History taking should reveal patient's risk factor. If the medical record shows high blood pressure, cardiac disease, transient vascular accidents, diabetes, dyslipidemia, coronary atherosclerosis, heavy smoking, old age, then such patient is prone to stroke and we should be prepared in the dental clinic. History of past attacks need to be elicited, date, seriousness, treatment, disabilities. These are situations when patient's speech is not affected, but he cannot realize the extent of the palsy. He's not aware of it, or situation when a patient with brain injury on his right side is neglecting the other side of the body. Blood pressure and pain should be monitored. Neurologist should be involved and consultant. If needed, dental treatment to reduce bleeding, for example, tooth extraction, pulpotomy, and subgingival scaling. Anticoagulant systemic medication may cause serious problem, and Dr. Hisham will talk about this later. If there is some other anticoagulant medication involved, it should be stopped several hours. This will be discussed later as well. The dentist should be ready for emergency intervention in case of local hemorrhage. The minimum number of anesthetic solutions should be used. For example, drugs and drug interaction. Number one, metronidazole should not be tried. If the patient shows symptoms of stroke, he should get oxygen therapy immediately and should be referred to hospital as soon as possible. Patient with transient TIA or with a stroke in their medical record have a very complex dental and periodontal pathology. So even though we have to eliminate any source of infection and inflammation, if patient shows minor physical disabilities after stroke, they can present poor oral hygiene. For such patient, dentists will advise the use of electric toothbrush, easier to handle, use of dental floss, oral irrigation, and prophylaxis using chlorhexidine and fluoride. Dijan suggested that the patient with acute ischemic stroke are frequently exposed to potential drug interactions. It is essential to identify potentially drug interactions in the patient as early as possible. Full attention should be paid when adding each new medication in therapy, particularly when a neurologist decides to prescribe antipsychotics such as risperidone. Thank you for listening.
Thank you, Prof.
I
Asma.
hope that I have answered my question. Should we be involved in such conferences? I think the answer is yes. We should be involved. We should be invited as dentists. Taking care of oral health status prior to the stroke is very essential. Thank you.
Thank you, Prof. Asma Faden, for the very informative lecture, as always. I would like to invite our second guest speaker, Dr. Hisham Abbas Komo. He's a consultant in maxillofacial surgery at King Abdulaziz University. He's the head of the Department of Operations and Anesthesia at the University Dental Hospital. He's the vice president of the Saudi Board of Maxillofacial Surgery program at King Abdulaziz University College of Dentistry.
Assalamu alaikum wa rahmatullahi wa barakatuh. Today I'm going to talk about the oral and maxillofacial surgery preparation of stroke patient. Usually this is considered as the second part of the dental management of stroke patient. Usually if we want to divide the stroke management of the dental field, we can divide into two main categories. The first, or our aims, for the preventive and restorative treatment, which is done by Dr. Asma. The second part is we usually try to minimize it or avoid it, which is the surgical part in the oral and maxillofacial surgery. First, I will talk about what is the rule or what is the guidance from the oral and maxillofacial surgery can be provided to the patient of stroke. Oral and maxillofacial surgery is considered as a one of the surgical specialty related to the dental field. Usually we're dealing with a patient for the tooth extraction or dental implant, or usually a patient having a facial, maxillofacial injury, a mandibular fracture, maxillary fracture. Also, we're dealing with the oral and maxillofacial and head and neck cancer. Sometimes patients are old and there is having an ulcer in the maxilla or in the mandible, or having swelling in the mandibular or maxilla, then diagnosed as a cancer. So we have to deal with the stroke patient. And as a maxillofacial surgeon, so we have to review all the mechanism of the medication, also related to the nature of the stroke. Also, sometimes the patient, a stroke patient, as an inpatient or as a bedridden, and develop dental abscess or head and neck facial cellulitis. So we have to deal with this infection, as we can see later, inshallah. First, what is the oral management of the stroke patient? First, we have to assess the nature and severity and the control and stability of the disease. For example, if the stroke happened to the patient during the last 6 months, so we try to avoid any elective procedure during this 6 months. Only we're going for the emergency treatment. Evaluation also for the risk factor that may happen for the patient. For example, if the patient having hypertension, diabetes, congestive heart failure, valvular heart disease, old age, mainly above 75, patient with dyslipidemia, patient with recent TIA or history of stroke. So we have to assess all risk factors before giving the decision for the treatment. We have to keep in our mind, for example, this patient now came to my outpatient clinic and patient with history of stroke. So we have to assess the severity of the stroke, because most of the patients with stroke patient having a loss of the protective reflex, difficulty in swallowing, no gag reflex. So during treatment, we have to keep good suctioning for the patient. And also we have to keep our mind to keep the patient upright, and extra care to avoid any aspiration of the foreign body for the patient. Reviewing the medication is the most important during dealing with the oral surgery. Most of the patient came to the oral surgery clinic of the stroke having antiplatelet or anticoagulant. So usually we should know what is the type of the medication and what is the mechanism of the medication itself. Otherwise, also the patient came to my clinic maybe need as an analgesic post-extraction or post-dental implant or any facial injuries. So which type of analgesic we have to give to the patient? Usually we try to avoid the aspirin or non-steroidal anti-inflammatory, because it will accelerate and increase the bleeding tendency for the patient. So we prefer usually to give the patient acetaminophen for pain analgesic. Again, also we have to evaluate the antibiotic of the patient. If the patient taking, for example, tetracycline or flagyl, we have to avoid it because it will increase the tendency of bleeding, especially if the patient on warfarin, because the metronidazole and tetracycline decrease the metabolism of the warfarin. So, as Dr. Asma mentioned, usually for the stroke patient, we usually try to give the patient short morning appointment and try to minimize the session of the treatment, also to give a traumatic procedure as much as we can. Usually, for the management of anticoagulant and antiplatelet patients, we can divide it into 5 categories. But previously, as a general rule, we have to explain to the patient about all the procedure, what will happen, and all the post-operative complication which may happen post-extraction or dental implant or any dental procedure. So, in any patient came to the clinic, we have to ask ourselves question: is this dental treatment causing pain or causing bleeding or no bleeding? If the answer yes or no, if yes, we have to review the medication. But if the answer no, so we deal with the patient with normal standard precaution. morning appointment, good suctioning, local anesthetic agent, but usually to try to minimize the local anesthetic agent, at least minimum 2 curpures. But if the patient, the dental procedure bloody, so now we have to go for the medication. We have to ask the patient or the patient physician, is this medication will be for prolonged time or only for limited time? If the answer, the medication only for the limited time, so we can delay the elective procedure till the patient finishes his course of the treatment or the medication. But if the answer no, the patient will have this course of medication for prolonged period of time, we have to review again the medical history. If the patient having other complications, congestive heart failure, renal disorder. If the patient having any other complications, such as congestive heart failure or diabetes, so we have to review all the medication, not only the related to the anticoagulant and antiplatelet. Then we can divide it into 5 categories. Direct oral anticoagulant, or the patient having on warfarin, which is the vitamin K antagonist. The other thing, the patient using the injectable anticoagulant, or the patient taking antiplatelet, or patient taking both, anticoagulant and antiplatelet. First, if the patient taking a direct oral anticoagulant, such as apixaban or rivaroxaban, usually the apixaban giving BID for the patient, 1 morning dose and 1 in the night dose. So we have to ask the patient, and also again, for how long he is on apixaban and what is the dose of apixaban. Then we have to ask ourselves, is this procedure, the dental procedure, less bleeding or high bleeding? If it is less bleeding, so we can start the treatment without any modification. But if the procedure is high bleeding tendency, so we have to consider the modification, which is advise the patient, if the patient on apixaban, BID, we hold the morning dose of apixaban and inform the patient to take the late dose or the night dose only. If the patient on rivaroxaban or indoxaban, usually this medication taking once daily. So we inform the patient to hold the morning dose and take it only in the night, or at least 4 hours after the procedure, to confirm there is a good homeostasis done for the patient. This is if the patient taking apixaban or rivaroxaban. So, what if the patient taking vitamin K antagonist, which is a warfarin, most common warfarin? So in this case, we have to ask the patient to do INR to evaluate the international normalization issue. What is the number? If it is 3.5 or less, so we can proceed with the dental procedure without any intervention or consideration. But if the INR above the 4 or above 3.5, here we have to contact with the hematologist to at least decrease the amount of the INR. Usually, what we will do, inform the patient to follow the bridging protocol, starting on enoxaparin and stop using the warfarin, and repeat the INR at least. Once the INR below the 3.5, so we can proceed with the surgical intervention by holding the morning dose of enoxaparin. After that, continue on warfarin and enoxaparin till the elevated, the therapeutic level of the INR. Again, if the INR for the patient 3.5, we can proceed immediately. This communication between the maxillofacial and the hematologist is the most important to prevent any complication for the patient, especially post-extraction. Sometimes the patients stop the enoxaparin and continue on warfarin, but still it's not reached to the therapeutic level, which may side effect for the patient. But if the patient taking injectable anticoagulants such as enoxaparin or diliparin, usually if the dose of the enoxaparin, it's only prophylaxis dose, which is usually around 2,000 units once daily, or the patient taking high dose of the anticoagulant from the enoxaparin, which is a therapeutic level, which is around 100 or 150 units per kg. Here, we should hold the morning dose of the enoxaparin then resume it at night or at least 4 to 6 hours post finishing the dental procedure. If the patient taking antiplatelet, if the patient only receive baby aspirin or aspirin only, so no need for any modification to adjust the dose or holding the dose. Previously, they stopped the aspirin 7 days. Then they did modification to stop it at least as a half-life for 3 days. But the new recommendation, we can proceed for any dental procedure with aspirin only. But if the patient taking aspirin and Plavix, again, the same protocol with aspirin and Plavix, either to contact with the physician to hold at least one of them or proceed with Plavix or aspirin. And you have to keep in mind and inform the patient, the bleeding tendency post-dental procedure will be high. So we have, after any dental procedure, do suturing, Surgicel, gel foam, use any local factor you have to decrease and minimize the bleeding post-surgical procedure. The fifth category, or the last category of our patient, stroke patient taking anticoagulant or antiplatelet together. Here we usually try to inform the patient, to inform the clinician and physician to hold the, adjust the anticoagulant, whatever it is, warfarin or enoxaparin, to stop it for a couple of days, and continue only on antiplatelet. But sometimes you cannot, especially if the patient having also again a cardiac prosthetic heart valve, or the patient having pulmonary embolism for the last 3 months. So usually they continue on anticoagulant, but we prefer to hold at least the antiplatelet and dealing with the anticoagulant as itself, either warfarin or enoxaparin. This is usually what happens in the oral and maxillofacial surgery clinic for the patient of the on the stroke patient. Usually we're dealing with antiplatelet and anticoagulants. So the take-home message, before any dealing as a surgical procedure, the communication between the neurologist or the physician of the patient and the maxillofacial surgery, it is important to minimize the risk of bleeding post-extraction. Thank you.
Thank you, Dr. Hisham. Now we would like to receive any questions from the audience, please. We can have the mic over there.
Thank you so much for the great presentation for both of you, our speakers. My question is for Dr. Asma regarding to the stroke patients who's under the big tube. Is there any, especially in the acute stage, is there any special instructions for the oral hygiene?
Can you repeat it again, please?
If the patient's under big tube, is there any special instruction for oral hygiene for this kind of patients?
Well, my message always try to eliminate any source of infection. So my answer, yes, we can start with quick scaling, okay, before any procedures, whether it is simple or surgical procedures. Always eliminate any source of infection, which is the calculus. It is our enemy here, especially with the stroke patients. So the answer, yes, we have to proceed first stage by eliminating the source of infection by at least simple scaling.
Thank you so much.
Any other question?
ما أدري في dental students حاضرين معانا.
Assalamu alaikum. Thank you all for your great presentations. I have questions to Dr. Asma. You mentioned that oral bacteria may be one of the reasons that people get stroke, yes?
It's not one of the reasons.
Yeah.
It should be in the high risk list, yes.
Okay. From your reading, have you ever comes across data that explain how can oral microbiome cause a stroke? Is there any pathway that oral bacteria can involve in which cause a stroke, like, for example, triggering immune system or releasing toxin or involved in like in gut microbiome, it's involved in gut-brain axis. But what about oral microbiome? How it can cause, from your reading or from your experience, how oral microbiome can cause a stroke? Which pathway involved in?
Okay. Actually, you have answered your question. The key answer of your question here is the chronicity of the inflammation. So if we have source of infection, bacteria, which causes inflammation, and it is chronic, the microbe can transfer to the bloodstream through the 4 ways I have mentioned. One of them is a direct to the bloodstream. Second is by triggering inflammatory response. And the third is the toxins itself. So the pathophysiology of behind this, it is more related periodontal status and the atherosclerosis, the type of stroke. It causes more lipid deposition and causing atherosclerosis more than the hemorrhagic type. So there is an evidence needs to be further investigated.
Okay. Another question: do you people who get stroke, do they have taking antibiotic before they get the stroke? Maybe antibiotic like decrease the diversity of the composition of microbiome or microbiome. Do you think there is something related to the compositions of microbiome or not?
I haven't read any studying before stroke, because nobody can predict stroke, as the doctor mentioned yesterday. When it happens, it happens. Okay, but I haven't been through a study that relates the change of oral flora by using the antibiotic and the stroke. Our focus now is not the oral flora itself. Our focus is the accumulation of the calculus itself. So whether you are using antibiotic or not, but you still have good oral hygiene, you're out of the list because your body can defend. But if you have accumulation of calculus and it causes periodontal inflammation, you are in the high risk list.
Okay, thank you so much. Thank you both.
Any other question? Okay, thank you. Both Dr. Asma Fadin and Dr. Hisham can have a seat. And now we would like to discuss the scientific paper for the first scientific session presented by Dr. Fathiya Ahmed Mirsal from Northern Borders University. Dr. Fathiya. You can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank all organizers about this amazing conference. Inshallah, we will start to talk about evaluation. My paper is evaluation of understanding and perception of a stroke risk factor among healthcare students at Northern Border University. We are know the health professional is a future health professional. The student is a health professional, future health student. So we will talk about this issue, inshallah. Me and Dr. Fadia. You can proceed. Next. Next. Our background, stroke has significant global societal and financial effect in the Middle East. It is becoming increasingly common and significant health concern. According to Saudi Arabia study, the annual prevalence is 29 per 100,000, stroke becoming a significant cause of illness and death. And it is becoming increasingly prevalent in Saudi Arabia. As a result, its effect on society and the economy have emerged as one of the most significant medical issues facing the kingdom. Sorry. Healthcare students greatly influence the treatment and result of stroke patients. Nonetheless, it is worthwhile to increase their understanding and proficiency with stroke management technique during their education. Additionally, evaluating healthcare student knowledge and comprehension is crucial since after graduation, they will likely be expected to care for stroke patients in emergency room or intensive care unit. Our research objective, this study aims to evaluate the understanding and perception of stroke risk factor among healthcare students at Northern Border University. Our methodology, research design, is a descriptive study design assessed the healthcare student understanding and perception of stroke risk factor. This study recruited healthcare students from 3 colleges: Nursing, Medicine, and Applied Science Medical College at Northern Border University, both male and female from 1st grade to 5th grade. They were 18 or 25 years old and agreed to participate in this study with confidence level 80%. A tool of data collection. The first part is socio-demographic student data such as age, gender, year of level, the college name. Second part, knowledge of stroke awareness, which includes 32 questions, was sorted in 4 categories: student general knowledge of stroke, student understanding stroke risk factor, and learning science. The first component addressed the management of stroke. The total score was computed to 100%, where 60% and more are considered satisfactory knowledge, and less than 60% were considered unsatisfactory knowledge. A result, the study found variation in stroke knowledge among healthcare students across the 3 colleges. While most students had satisfactory knowledge of stroke risk factor and learning science, there were areas of inadequate understanding. They also study identified area for improvement in stroke education and training. The results highlight the need for ongoing postgraduate education to keep healthcare students updated on new research finding and development of managing stroke risk factor. This figure shows that in nearly 2/3 or more than 2/3 of nursing students had a satisfactory knowledge, while nearly 3/4 of medicine college had satisfactory knowledge. Also, less than 2/3 of applied medical science had satisfactory knowledge. A conclusion. The study emphasized the importance of enhancing healthcare students as a future healthcare professional of a stroke risk factor for effective prevention and patient outcome. It emphasized the need of multidisciplinary collaboration in stroke management and healthcare. It emphasized the need for continuous postgraduate education to keep medical students updated on stroke prevention and management research. Thank you. Any question?
Thank you, Dr. Fathia. You can have a seat. Any question from the audience? There's a question there. We can.
Assalamu alaikum. Dr. Ala from Radiological Science Department. You mentioned that there is 3 colleges, medicine, nursing, and applied science. Is any method for detection of a stroke has mentioned it in the study? Or you have a questionnaire related to the medical imaging with the stroke?
Involved 3 college, nursing, medicine, and applied science. But للأسف الفارماكولوجي college not involved because I don't reach it yet. We are برضو involved the risk factor as warning sign or risk factor stroke management as it. Okay.
Thank you for the question. Any other question from the audience?
Assalamu alaikum, Dr. Amira Yahya from College of Nursing. Thank you, Dr. Fathia, for your presentations. My questions, how you measure the perception of the student? Did you doing mixed method or only descriptive? But how you measure the perceptions? Thank you.
Yes. The perception measured according to some tool, the tool of knowledge. Okay, the tool of knowledge, as I said, computed to 100%. 100%, 60% are satisfactory knowledge and perception. Low 60% as unsatisfactory knowledge and perception.
Thank you for the question. Any other question? Okay, thank you so much for attending this session.
نشكر رئيس الجلسة دكتور ريم والمتحدثون. الآن بإمكانكم أخذ استراحة قصيرة والاستمتاع بالملصقات العلمية، وسنعود إن شاء الله 10:10 تماماً لبدء الجلسة الثانية. شكراً. Oh, Dr. Kadina Sarafna. So I think we should start. Like 3 minutes. شو يسوي له؟ ايه خلاص نبي نسوي classes. شكرا. We'll start, right? We should start. نستأذنكم لبدء الجلسة الثانية. والآن تبدأ الجلسة العلمية الثانية بعنوان التغذية وإدارة السكري لمرضى السكتات الدماغية. لإدارة الجلسة نرحب بالدكتورة لينا البلوي. والمتحدثون كل من والمتحدثون كل من دكتور عبد العزيز المسلم and Dr. محمد Chad.
نور. Welcome everyone to the second scientific session. It's my pleasure to present Dr. Abdelaziz Msallam. Dr. Abdelaziz is an assistant professor in internal medicine at Mujma'ah University. He is consultant in physical medicine and rehabilitation. Dr. Abdelaziz will be speaking about rehabilitation of stroke patient and the post-stroke life quality. Welcome, Dr. Abdelaziz.
Assalamu alaikum. Assalamu alaikum. Welcome for all, and thank you for the committee stroke rehabilitation committee for inviting me as speakers. Today, inshallah, I will talking as a brief in acute stroke rehabilitation and the medical or most common comorbidity in the stroke rehabilitation. Before I started, what the okay. Before I started, what the best time to start rehabilitation? يعني when we think that now we can start the rehabilitation. actually, the after stroke control by acute teams, this is the time when the best time to start rehabilitation and set up the short-term and long-term goals for rehabilitation plans and discuss with the family and the patient himself. This is the time for the stroke rehab. Once the patient recovers from stroke, we think for next plan is a stroke rehabilitation to improve the quality of life and functional recovery. Sorry, the pointer. If you go to what the stroke rehabilitation, next slide, please. Yeah, this one. Yeah, sorry. Yeah, what is stroke rehabilitation? As I mentioned before, is supposed to start as soon as possible to avoid potential complications. According to international classification function, which is developed by WHO, the defined stroke rehabilitation is, or the main goals is to optimize functioning interaction with the environment. It's meaning we consider the patient at all, physically and mentally and environment. You take the patient as all the in general. This is why if you see there, according to the international classification function, ICF, if you see here many impairment in stroke patients and many activity or disability and handicaps. In the stroke rehabilitation, we focus for all the phases. Okay, all the impairment, we list many impairment, have list of many activity or disability and the handicaps. For example, the gait, weakness, spasticity, whatever, and which affect in her or his activity. This is why if you see maybe I didn't maybe mention it before it. If you see here, we work in the stroke rehabilitation as multidisciplinary team. The patient is the cornerstone of the teams. If you say, suppose we discuss the plan, patient and our family, the plan and the barrier for every single goal as short-term and long-term. If you see all the nursing, dietitian, speech, physiotherapist, psychologist, occupational therapist, social worker, physiotherapist as well, physiatrist. We consider the patient is the cornerstone for acute rehabilitation. We work together to set the goals and discuss and manage the barrier if there is barrier. Let me start it for the phases of stroke. If you see here, you have many phases. In acute care, in acute stroke unit, okay, in patient rehabilitation, and at home health care or outpatient as outpatient OPD. According to the goals, we send the patient to home health care or outpatient. So this is the phases of a stroke. Let me talk about the inpatient rehabilitation and acute phases. If you see here, most common the causes of death during the stroke in first month, if you see, you can manage. We can manage before it's happened, like stroke, aspiration pneumonia as secondary dysphagia, cardiac event, MI, pulmonary embolism secondary to deep venous thrombosis is can managed if you managed before it's happened. So, if you see here, the first thing before started acute rehabilitation is control risk factor, or started the second prevention. Already patient has stroke, so we don't need another stroke or recurrent stroke. We need to control the second risk factor according to the patients. If patient is diabetes, hypertensive, cardiac vascular disease, hyperemia, whatever. We can control the risk factor from the beginning. dysphagia is affect more than dysphagia is common among stroke patients. Affect more than 50% of stroke patients, and fortunately is just have low percentage or 7 to 11 will become a chronic dysphagia and lead to aspiration pneumonia or malnutrition or the dehydration. Second most common impairment is the neurological bladder. The most common impairment you see in the patient is with the stroke patient, is secondary to neurological bladder. Patient, you have suppose you started bladder program soon as possible. After patient control by the acute teams, you can start the bladder program to rule out recurrent urinary tract infection and septicemia as long-term complication. Shoulder pain or hemiplegic shoulder pain, you have mechanical or neurological shoulder pain with differential diagnosis, neurological as secondary to weakness, spasticity, complex regional pain syndrome, or mechanical rotator cuff or impingement of frozen shoulder. Suppose with early mobilization of shoulder, you can control for the shoulder pain. The idea is don't wait the patient to have shoulder pain to start it, rehabilitation or mobilization. Spasticity is common impairment among stroke patients. Is commonly with elbow flexor, shoulder flexor, and hand flexor muscles. So early immobilization can decrease this spasticity and prevent the contraction as long term. The DVT is commonly seen in the patient and is considered as fatal complication and easy to prevent it by mobilization and DVT prophylaxis according to the patient status. If you go to next objective, what the functional outcome will affect the patient and the quality of life, you see here many items: stroke or recurrent stroke, large CBS stroke, UTI. You can manage early depression. You have any history of depression, cognitive deficit, and have delay medical and rehabilitation care, poor social support, and cardiac disease, and there is global aphasia. There's all the items is risk factor and effect for functional outcome. I think this last slide, if you see here, the home message for you, the multidisciplinary teams is cornerstone for stroke rehabilitations and starting rehabilitation as soon as possible after acute stroke is controlled. Thank you.
Thank you, Dr. Abdelaziz, for this enlightening presentation. And now for our second talk, I would like to welcome Dr. Mohammed Dalshad. Dr. Mohammed is an associate professor of physiology in College of Applied Medical Sciences at Majma'ah University. He will talk about gastric complication in stroke patients, present challenges, and future point of view. Welcome, Dr. Mohammed.
My colleague introduced about me. Myself is Muhammad Dilshad Manzar. I'm working in College of Nursing, mashallah, now. Previously, we were in College of Health Sciences. I will be talking about gastrointestinal complications, the major gastrointestinal complications that happens in especially hemorrhagic patients. So one of the subtypes of this stroke. So why did I choose the topic? Now, my students are also here, mostly masters and undergrads. So first I will come to why did I select this topic. Now, the selection of the topic is, when I went to review the literature, I found most of the studies are talking about the gastrointestinal complication, especially the reviews I'm talking about. They're talking about the gastrointestinal complication, the major ones, in the case of ischemic stroke. They're not talking, most of them, they are not talking about hemorrhagic stroke. That's why I planned this study. So this is a part of the systematic review that I'm doing. Some concise and brief outcome of that systematic review I will be presenting today. Sorry. So, purpose, gastrointestinal complications, they occur in a stroke, other conditions like intracranial lesions, craniotomy. Now, gastrointestinal complications, including GI bleeding, they are associated with poor health outcome, that is prognosis and all, and morbidity. Research efforts to systematically review the incidence of major gastrointestinal complications in hemorrhagic stroke has not been done. That's why this paper I'm presenting here. Now, methods that I use was the major databases. Some of them were searched. Cochrane Library, Medline, Sinhal, and the Google Scholar. As of the 4th January, so recent most articles I collected. Now, the 4 major groups of gastrointestinal complications that I grouped, okay, that was dysphagia, GI bleeding, dysbiosis, and GI hypermobility that may express in forms of constipation, intestinal paralysis or iliac paralysis. Now, first we come to, now we'll talk about all of these major complications separately, how the evidences exist. So we talk about the dysphagia, okay, in hemorrhagic stroke. Now, these are the studies that were included in the systematic review. 5 studies are included, okay. Now, you can see variable number of sample sizes. Now, this is too much of literature here. So what I did, I made a summary for all the findings in this table so that you can take easy home message from this. If you read the table here, it's too lengthy. So I come to this. Now we see the 5 studies are included. The sample size is quite variable. It starts from 30 to, you can see, that big number. Then the incidence of dysphagia is also varying. First thing can be understood from this sample size itself. Now the differences in the incidence rate. Incidence is 10.2 to 76.7, so quite big range of variation is there. Now the this third point I'm reading out, it is from a paper from Canada, and it's based on the Ontario Stroke Registry, one of the best stroke registries, and we are talking about one of the best health infrastructure in the world, Canadian health infrastructure. Now what the paper says is ICH, that is intracerebral hemorrhagic stroke, patients were less likely to receive dysphagia screening, though they were more likely to fail the test, but still they were less likely to receive the screening for dysphagia. This lack of screening might have contributed to underreporting, first thing, and consequently led to the wide variation in the summary of the studies we are seeing. Then we come to the 4th summary, that is predictor selection across the study. Now, whenever we choose the predictors, so the dependent variable was the hemorrhagic stroke. Now we see the predictor selection is across the studies, it is not consistent. Now what that will do? Now if we have to summarize, we have to find the consistent predictors that may help us in prognosis of the disease. We can use them as clinical markers. If the studies, they are not consistent in selection, that can be a problem. Now, we see that in conclusion, those are efforts to increase dysphagia in screening. So outcome of the dysphagia incidence across these studies, so what I conclude from that is, there should be effort to increase the dysphagia screening. To do that, emergency care providers, including the physicians in the emergency room and the nurses, they should be periodically trained in the various types of dysphagia screening tools and tests are available, 6, 7. All of they should be periodically trained. Then the future research may explore, then it comes to the predictor selection. Future research may explore and identify more predictors that are pertinent to infer about the prognosis of hemorrhagic stroke patients. Okay, so that is lacking till now in the study, so that is one of the future perspectives. Then we come to the incidence of second major GI complication. We come to the incidence of GI bleeding. Here again, we have, like in the systematic reviews, 6 articles are included. Now, the summary from this table, huge table, we can have few pick home messages like 6 studies were included. Again, the variation is there in the sample size, but here we have now less variation. Now, the incidence of GI bleeding is in purely ICH cases is homogeneous. Then we see the incidence of GI bleeding in SAH, that is subarachnoid hemorrhage, is more variable. It is starting from 2.9 to 4.9 to 17.9 in SAH cases, that is aneurysmal subarachnoid hemorrhage cases. Then we see the predictor selection. Now, this here is the strength of the studies. Compared to dysphagia, the predictor selection across studies in the case of GI bleeding, they are more consistent. Now once we have consistent predictors, now clinically relevant predictors, we had many of them. We can go to the table or some of them I have identified for you. So I will stick here. So age, size of the hematoma, septicemia. Then there is a questionnaire tool to evaluate this Glasgow Coma scale. Lower right quadrant Hounsfield unit values. This is coming from radiation unit, then ICH volume, etc. These can be explored to plan care for future cases. Then in comparison to dysphagia, the list of predictors explored for GI bleeding is more considered. This I already told you. Now the third point is, what is the benefit? I have been talking about consistent predictors, please. So what is the benefit of talking about consistent predictors? Once we have a list of consistent predictors, we can use it to develop a scale. Now, so this is my idea for the future perspective, especially with respect to GI bleeding and hemorrhagic stroke patients. The future studies, they can target to develop a composite score based on the consistent predictors across these studies and try to see that and do the ROC curve analysis and all, and try to see that composite score that they have developed. It is more likely, I'm talking based on the statistical considerations, it is more likely to predict the prognosis outcome. Okay. So this is one benefit because of the strength of the study in this area. Then we come to the third major GI complication, that is dysbiosis in hemorrhage. This one picture I brought from my studies, again a narrative review recently published in Frontiers group. Now here you can see the two pictures are there, left panel and right panel. The left panel is showing you when there is immune homeostasis, which is of a healthy brain. The right panel, picture in the right panel is showing you of a stroke patient, what happens. So this immune homeostasis is disturbed. So what is happening is once the stroke is there, you can see, I wrote in the literature there, post-stroke activated sympathetic nervous system activation is there, HP axis, hypothalamus pituitary axis that is activated, and then you have the release of DMPs, that is damage associated membrane molecular players. They cause dysbiosis, then they cause paralytic ileus, and then immune cell activation is there. Now they go in overdrive. They're not just activated, they will go in overdrive. This overdrive will lead to the immune cell overdrive. What they will do is, they will release toxic cytokines, free radicals and proteases. Okay, and these will lead to damage of the epithelium, the mucous membrane that will be damaged. So this leads to intestinal bacterial invasion, and that can finally express as neuroinflammation. Now, this was about dysbiosis. Then we come to the studies that have studied the association between hemorrhagic stroke patients and dysbiosis incidence. Okay. Now, the 3 studies are included in this review. Now, you see the summary from those studies. What we got is that sample sizes is quite homogeneous. The incidence of dysbiosis in ICH and cerebral aneurysm, rupture, and hemorrhagic stroke has been shown in a small sample study, so we do not have large-scale studies, so it needs to be established. Now, the microbial correlates of dysbiosis are not consistent. So this inter-study variation makes it difficult to conclude, what to conclude from this. This is an interesting area, especially this association axis between hemorrhagic patients, this dysbiosis, and hemorrhagic stroke patients, but it needs to be established. Now, furthermore, experimental studies, please mind it, these experimental studies I'm talking about, these are not the clinical experimental studies, these are experimental studies in animal models. So the experimental studies in the animal model, they have shown more promising results, but we need to replicate those results in the human beings. Now, what they have shown is that the rebalance of dysbiotic microbiota, okay, can be done using prebiotics or probiotics with food supplements, and the dysbiotic microbiota, their population can be managed depleted by using antibiotics. Okay. But these results are from experimental studies in animal models. The future perspective should be, first thing is, more rigorous studies are needed, more larger sample sizes, more research with larger sample sizes, and especially when we are talking about the gut microbes, so we need to consider about the different dietary profiles across different cultures. Okay, that will help in further establishing this relationship of dysbiosis and GI complications in hemorrhagic patients. Now, about the fourth one, that is incidence of GI hypomobility and in the intestinal paralysis, I'm not presenting today. Inshallah, I hope soon I will be publishing a systematic review, all of this together. To keep the things brief for the conference, I knowingly obliterated this aspect. Okay. Now, then we come to the summary of all this. So what did you learn, we see together? We saw about in specific hemorrhagic patients, we have 4 groups of major GI complication. From that, 3, okay? So of those 3 relationships we studied. Now, of those 3, what can I conclude from that summary? So the relation of hemorrhagic stroke with dysphagia, GI bleeding is well established, but for the dysbiosis, it needs more research. Now, predictor selection for these stroke GIT complications may benefit from exploring consistent and clinically relevant markers, especially those which are relevant which can be used for prognosis. And why? They can help in planning the care of the patient. Beforehand, it can help inform the nurses and the physician how to plan, what is expected prognosis. Now, and then the last one, I already told you before, we had the strongest evidence coming from GI bleeding and the GI bleeding and hemorrhagic stroke, this axis. So we had consistent list of predictors. We can use that to develop a composite score. This project can be taken by future studies. Now, last sentence based on my experience here, what should be the future perspective with respect to stroke research in Saudi Arabia? Alhamdulillah, this conference has given us a good platform to discuss the ideas. This is the beginning. We should carry this energy and enthusiasm forward. My suggestion, one of the suggestion is, humble suggestion is, that we can try to develop a stroke registry on the model of a stroke registry that is in China. They have a national stroke registry. Canada also has a district-wise stroke registries. Japan also has stroke registries. Now here, maintaining the data, we all are doing, our physicians, they are doing work. It is not that a stroke only happens in America. A stroke happens everywhere. Wherever humans are there, a stroke will be there. So people are working, data is being lost. So we need to be more careful, more diligent in storing the data. There I suggest that we have, alhamdulillah, a good number of basic science experts who can be utilized in clinical postings to help in data curation and maintenance and those data curation, because first line of evidence will come from association studies. Once you have strong evidences from association studies, then only you can go for interventional design. And especially because a stroke patient you are talking about, you cannot design anything on a flimsy ground. You need to be you should start from a very firm footing. The evidence should be strong. For that, you need to have studies, observational studies with large sample sizes. From where will you get? If you have registry, it's so simple. You can design the retrospective studies. So my suggestion, take-home message is, inshallah, we should plan for a national stroke registry in Saudi Arabia. Thank you very much.
Thank you, Dr. Muhammad, for this enriching presentation. Before we open the floor for questions, I would like to ask our colleague, Dr. Abdulaziz, in regards to spasticity as one of the debilitating complications of stroke, is there any measures that can decrease the incidence or decrease the worsening of such complication?
The spasticity is considered as impairment. We can prevent it early by just early mobilization. It's according to neuroplasticity in acute phases. But we can prevent it by early mobilization. The idea is the spasticity is not disease itself. It leads to many complications like contracture, bed sores, pressure sores. You can manage early by mobilization or by spasticity control it.
Thank you very much. So let's open the floor for any questions. Please raise your hand for any questions. Yes, we have here in the middle. Please, can you provide them with a microphone?
Assalamu alaikum. I am Dr. Muhammad Yasin Sikandar from College of Applied Medical Sciences. My question is to Dr. Muhammad Dilshad. Dr. Dilshad, since you presented about the stroke and its complications and consistent predictors, and you said the stroke occurrence depends on dietary habits and living lifestyle diseases. So my question is, there are two questions back to back. Question number one, are there any study conducted across the globe, country-wise? And this is number one question. Second question, since it is based on dietary habits, what about which country comes at the top, which country comes at the bottom of the stroke occurrence and its management?
Can I answer?
Yes.
Assalamu alaikum. Thank you, Dr. Yasin, for your question. I think there was one misunderstanding. I didn't say that a stroke happens because of the dietary habits. Okay. I said that a stroke and one of the relationship, okay. We were talking about dysbiosis. So hemorrhagic stroke, okay, in patients who are having dysbiosis, this axis may depend on, okay, that was my suggestion, because of the three axes we talked today. We talked about dysphagia, we talked about GI bleeding, we talked about the third one was dysbiosis, that is disturbance in the microbiota in the GI tract. Now, these disturbances we are talking about, so the evidences in this aspect is the weakest. Okay? So, furthermore, so to strengthen the future studies, I suggest, first point is the evidence is still what we have is weak. And to conclude about this axis, this relationship, is it strong or not? The future study should target different types of dietary habits, because microbiotas, they will depend. The GI tract microbiota, we have evidences that different types of nutrition habits will lead to different types of microbiota in the GI tract, in the normal microflora. Now, how this change in a different dietary profiles, this is what I suggested should be done. Okay. Now, about the studies, so I expect there would not be studies, because I already reviewed this systematically and I could find only 3 papers. So what you asked, the second part, I expect no more evidences would be there. So we expect, inshallah, in future, the studies will be targeting these areas. Good perspective you added. Inshallah, the things we'll see, things will be growing in that direction.
Thank you, Doctor.
Any further questions? Yes, please, someone there.
Assalamu alaikum. I am Asim Nueder, a student from College Nursing. My question for Dr. Muhammad, a patient with dysphagia will affect stomach function because he will in bed for a long time, and how to avoid complications that affect the stomach.
Assalamu alaikum. Thank you for your question. Now, dysphagia, definitely, because once we have problems in swallowing, so that will definitely in the long term, in the short term also, in both aspects, this will lead to problems because the food is, difficulty is reaching itself. So first line of treatment that we see is intubations are done. Okay, different intubations are done to at least provide the food. Okay, in the long course, now if the intubation exists, there can be different, now we have to see the prognosis. Now the first group of patients, if the gastronomy tubes and all we can remove quickly, then, and the dysphagia goes off, the symptom goes off quickly, then means the patient can be started on different types of meal. So you have the variety of meals possibility. But if that cannot be done, intubation continues for long. So nutritional deficiencies, and we have to be careful in what we are supplying through the tubes. Okay, this is it. So this can be managed, but it is all managed in the routine course. But there will definitely we have to be watchful.
Okay, just for additions. For dysphagia, you have three phases for swallowing at all. You have oral and pharyngeal and esophagus. What is the pathology? According to the pathology, we can decide how can intervention. Other things with for dysphagia, routine or in our routine day work, the swallowing assessment at bedside or by using radiologist, MBS or phase is essential part for the swallowing assessment to rule out long-term complications as mentioned by Dr. Mohammed.
Thank you very much. Any questions? Yes, please.
Assalamu alaikum. This is Mohammed from College of Applied Medical Science. My question regarding Dr. Abdulaziz Musallam. Is there any role of product therapy on specificity recovery, and what is the outcome?
Again, Dr. Malesh. Any?
Is there any role of products therapy and on spasticity recovery, and what is the outcome?
Spasticity?
Yes.
Yeah, see, the patient, if he has upper motor neuron lesion, stroke is considered upper motor neuron lesion, the spasticity this coming as the part. A stroke patient will have pattern of spasticity, as I mentioned, elbow flexor and extensor for lower limbs. The air mobilization is, they have many treatment or underlying treatment according to the degree and severity. Sometimes no need for any intervention, just mobilization and range of motion, whatever, and maybe can go to the next steps for the GBA, GABA analogs, baclofen, whatever, and maybe go to the long term for the Botox or the and for maybe we consider intrathecal baclofen. It is according to the severity. According to the severity, according to the function outcome of the patient itself.
Thank you,
Doctor. We can still have, actually it's now time for the scientific paper now, presented by Dr. Abdulaziz Al-Sharif from Al-Jof University. Thank you, our speakers.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Abdulaziz Al-Sharif, Assistant Professor of Physical Therapy for Neurology and Neurosurgery, Faculty of Applied Medical Science, Jove University. Today, inshallah, we will talk about a paper. Its title is Effect of Lower Limb Sensory Training on Postural Stability in Stroke Patients, which is a randomized controlled trial. At first, a small introduction or a brief introduction about the title. Stroke is the disturbance of cerebral function that lasts more than 24 hours and appears to be vascular in origin. An ischemic stroke is the common, which is the most common type. It may be like 80% or 87% according to different articles in 2022. Postural stability or postural instability is, or impaired balance is not uncommon. It's the most common problem in stroke survivors. It may get affected by disturbance it may result from a disturbance associated with different systems that are regulating postural or psychological factors due to safety concerns. Stroke significantly alters the symmetry of weight bearing on both lower extremities and maybe more on the more affected lower extremity. Less weight bearing on the more affected side, which may lead to further disuse atrophy and disuse weakness on the more affected side. This can persist for years after injury, encouraging the more learned non-use of the paretic side, which may be due to lack of sensory awareness of the more affected side, or may be due to limitations of overall motor functions, which may impair further independence in stroke patients. According to our interventions, which is sensory retraining or sensory training, which is used to improve the sensory input on the more affected lower extremity, which may have a positive effect on postural control and cortical reorganizations according to American Heart Association and American Stroke Association. Sensory-based interventions can be introduced in form of active sensory retraining or passive sensory retraining. Active sensory training, like proprioceptive training, and passive sensory training, it may be like thermal or electrical stimulation. Despite the increasing interest in sensory-based interventions, still we need more research in these areas according to American Heart Association and American Stroke Association guidelines. So the purpose of our study is to determine the efficacy of lower limb sensory retraining on postural stability in stroke patients. And here in our study, we are talking about subacute stroke patients, not all stroke patients, which is ranged from 3 to 6 months after the affection. So the methodology and subjects of our study, 30 male patients were recruited from the Faculty of Physical Therapy outpatient clinics from the period of 2020, January, to 2022. All patients were ischemic stroke patients in the anterior circulation. We choose the anterior circulation because the most affected part of the patient's body is the lower extremity, which is more than affection of the upper extremity. All the patients were recruited from the period of 3 to 6 months after the onset of stroke. All patients had adequate cognitive capacity, and all patients were ambulant. Patients were selected from the Faculty of Physical Therapy, Cairo University, outpatient clinics, and stroke specialized clinic, Faculty of Medicine, Cairo University. The inclusion criteria, in summary, was the patient's age ranged from 50 to 65 years, and all patients were males. All participants were an ischemic stroke patient on the anterior circulation, like we said. Duration of illness ranged from 3 to 6 months, like subacute stroke. All patients had mild spasticity, 1 to 1 plus, according to modified Ashworth scale, and all patients were ambulant. All patients had additional adequate cognitive and communication abilities. Patient had a body mass index not exceeding 35. The exclusion criteria of our study was musculoskeletal disorders, which may have a negative effect on the lower extremity, and cognitive impairment in a patient which had a cognitive impairment, which according to many mental state examination, less than 24 score. Patients with cognitive with congestive heart failure, unstable angina, shortness of breath, and patients with visual or auditory impairments. Patients with any history of vestibular dysfunctions, patients with diabetic neuropathy, and patients with any neurological impairment other than stroke, and patients with cervical cord myelopathy. It's a summary of the flow chart of the study. Assessed for eligibility was 43 patients, excluded about 13 patients, and randomized 30 patients. Control group and the study group all were with 15 patients, and all were analyzed. Materials and methods. All patients were assessed by two different parts of assessment. The first was the Berg balance scale, which was used for assessment of the dynamic balance, which is composed of 14 different items, and the total score was 56. This is a sample of the parts of the Berg balance scale. And the other part was the Biodex balance system, which is an objective assessment tool for assessment of postural stability, which is valid and reliable. This gave us 3 different indices like anteroposterior stability index and mediolateral stability index, and finally the overall stability index. All patients were assessed with eye open and eye closed. This is a summary of the selected physical therapy program, which is composed of stretching exercise and facilitation for the weak muscles, and strengthening exercise for the muscle exceeding grade 3, and like different straight leg raising, clamshell exercise, and bridging, and all the exercises were done in 3 sets. Each set consisted of 10 repetitions in 90-minute sessions, 3 times per week for 6 weeks. These are examples of the selected physical therapy program, like clamshell exercise, straight leg raising exercise, and bridging exercise. This is a summary of the sensory-based interventions. Like we said, we have 2 types of sensory-based interventions. The first type, which is the active part, which is a proprioceptive training, and the passive part, which is TENS, or transcutaneous electrical nerve stimulation. At first, the active sensory training, which is the proprioceptive training, this type of all these interventions were given to the patient in the study group only, or group A. The program consists of 3 phases of training. We will see they will see the images after a minute. All the patients were standing in a step-standing position. The first phase was done with a soft, stable surface, like a block. The second and third phase, we used a balance board. Each phase has a series of tasks done in both eyes open and eye closed conditions. These are pictures of phase 1. At first, the patient was standing, like step standing, with the more affected lower extremity was on the block, and the other lower extremity, or the less affected lower extremity, on the ground. And the patient asked it to stand still for 20 seconds. In the next task, the patient was asked to move his upper extremities in different directions for postural stability and for more weight bearing on the more affected lower extremity. A third picture, as we see, the patient asked to change or switch his lower extremities to stand with a step standing on a block on the less affected lower extremity, and the other lower extremity should be on the ground, directly on the ground. And the final step, the patient was asked to move the upper extremities in different directions for posterior stability and to have more weight bearing on the more affected lower extremity. The second phase task, the patient was asked to change. We removed the soft block, and we used a balance board. At the first picture, as we see, where the patient was asked to put his more affected lower extremity on the balance board and was asked to stand still for 20 seconds. Then the second picture, the patient was asked to stand and to move his upper extremities in different directions for posterior stability and for more weight bearing on the more affected lower extremity. Then, like we said, the patient was asked to switch his lower extremity and to stand, like step standing, with the less affected lower extremity on the balance board and stand still for 20 seconds. And this should be repeated in eyes open and eyes closed conditions. And finally, the patient was standing and asked to move in different directions to allow more weight bearing on the more affected side. At phase 3, the patient was standing on the balance board, two-dimensional balance board, with both lower extremities on the balance board and stand still. Then the patient was asked to move his upper extremities in different directions to assure more and more postural stability. It's the second part of the treatment, our intervention, it's a passive sensory stimulation. Like all we know, transcutaneous electrical nerve stimulation was delivered by a Chattanooga device. The parameters of using TENS were the pulse width was 200 microseconds. It was delivered at a frequency of 100 hertz for 30-minute session. Electrode placement was like two channels. The first channel was placed on the belly of the calf muscle, and the second channel was placed on the common peroneal nerve. This is a summary of our results. At first, the results of the Biodex balance system indices, effect of treatment on anteroposterior stability index in both eye open and eye closed conditions. There is a significant difference in favor of the study group regarding anteroposterior stability index in both eye open and eye closed conditions. The effect of treatment on mediolateral stability index, there is a significant difference in favor of the study group regarding the mediolateral stability index in both conditions, eye open and eye closed. And finally, the effect of treatment on overall stability index, the same result, significant difference in favor of the study group. And the second part of our assessment, which is Berg balance scale, there is significant difference also in favor of the study group. Conclusions, considering the conclusions, we have to conclude that using different types of sensory-based interventions, like we said, passive and active sensory training may have a significant effect on postural control in subacute stroke patients, and we can use it in our programs of physical therapy. The results of this study point out the importance of sensory-based interventions alongside the motor part of the assessment. Or as a physiotherapist, we use the motor part of the assessment. We have to consider more postural stability, more weight bearing on the more affected lower extremity to increase the sensory feedback from the more affected side and to induce cortical reorganizations and neural plasticity and to improve the patient conditions. Also, using proprioceptive training, focusing on encouraging the patient to bear weight on the more affected side may have a positive effect on balance and postural stability in patients with a stroke. And finally, this was the references. Yeah, thank you.
Thank you, Dr. Abdulaziz, for your presentation. We still have 1 minute for questions. I have one question in regards to your inclusion criteria. Since aging is associated with more risk of stroke, why haven't you, is there a reason why you did not include people who are above 65-year-old?
Yeah. We all know that stroke patients appear more in old age, like 50 or 60 or more than 60. We have just in our study, we tried to be more specific in an age range of from 50 to 64 to make the results more consistent. And also we asked the patient we recruited different patients from 3 to 6 months after the injury, like only subacute stage of stroke. We didn't include the acute stage stroke patient or chronic stroke patients.
Thank you very much. Any question from the audience? Yes, please. Someone here have a question?
أولاً السلام عليكم. Thank you so much, Doctor. First, welcome to المجمعة. My question is, since osteoarthritis is common above 50 years, so how will you manage these patients if they have a stroke? And how you can exclude them from the study? Thank you.
Yeah. Thank you, Dr. Alaykum Salam Barakatuh. I think you have a general question regarding treatment and assessment of stroke patients. Stroke patients have different deficits, like motor deficits. All as a physiotherapist, Think like stroke patients have motor problems. And according to the reality, stroke patients don't have only motor deficits, they have perceptual deficits. They have sensory deficits that we should consider these parts of problems in our designing of the different physical therapy programs. Also have cognitive deficits. Stroke patients have different deficits. So we can manage stroke patients according to the assessments. You should have a good assessment, and you should use different outcome measures to conclude the problems in a problem list. Then you should treat different problems according to different physical therapy schools. You can use a Bobath or brainstorm approaches or different physical therapy approaches like motor learning and task-specific training. The idea, all stroke patients should be managed as a special case, and the program should be tailored according to the patient's problems. It's not like designed program for all patients. We should follow this program. Here in our study, we focus on the sensory training part, which I think it's a missed part of treatment. Well, all of physiotherapists, we have the different concept of stroke patients like hemiplegia, only the motor part, only the motor affection. Here, we focus on the sensory part of assessment and its reflection on postural instability and its reflection on the functional activities of the patients. We insist on these parts, because we think it's somewhat of a missed part of treatment. Thank you.
Thank you so much.
Any addition? We can still have one more question. So I think we're going to conclude this session. Oh, yes, please. Someone has a question from here? Yes, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Ahmed Sahli from Jazan University. Thank you very much for your great presentation, Doctor. I was wondering about one of the inclusion criteria, the only including male participants. What was the reason for that? Thank you very much.
Yeah. Simply, we can generalize the inclusion criteria and include both male and female patients. But we all know that stroke is more common in male patients, and we try to be more specific in our inclusion criteria to be more specific regarding the results and the conclusions. You can include both male and female, and stroke, like all our professors said from the starting of the conference, is present in all male and female subjects, but it's more common in male, according to reference, which is a physical rehabilitation, which is one of the main books of physical therapy or main reference physical therapy. Male patients, stroke patients is more common in male, and it may be higher in female just after the age of 81 or 82 years old. We just included the patient's age from 50 to 65, and stroke is more prevalent in male than female in this age.
Thank you very much. So we're going to conclude our session. Thank you very much all for your attendance.
شكرا دكتورة لينا بلوي، شكرا للمتحدثين. ننتقل للجلسة العلمية الثالثة لهذا اليوم والأخيرة. رئيسة الجلسة تتفضل دكتور وداد العنزي. بروفيسور رائد البرادعي دكتور مشاري العلي. عنوان هذه الجلسة الوقاية من الجلطات الدماغية.
Good afternoon, everybody. Sorry, my voice is fatigued today. Sorry. I'm really thrilled to be with you today as a moderator of the third session in one of the important stroke conference I would like to welcoming our speaker, Dr. Raad. Sorry. And Dr. Mishari.
You forgot me? You have Alzheimer?
We will commence our presentation with our speaker, and then we will open the floor for a question from the audience. I will start with our first speaker, Dr. Raad al-Baradi. Dr. Raad, he holds a distinguished position as a professor of pathology at Majma University. He is also serves as a histology and cell science consultant for Saudi Commission classification for medical specialization. Dr. Raad expertise extends to his role as a professor of histology and supervisor of research chair Sheikh Abdullah Tuwaijri for stroke cases at Majma University. Welcome, Doctor.
Hello and welcome to my talk. Can I see my talk? Yes. Today, first, I want to talk about the problem. Second, to solve the problem. Third, to do research. Four, to get result. Then to move to second stage, which you have to patent your research. This is a type of research is accumulated between research and to go to the top. I am at this stage after we patent, I am struggling on industrial. Let us go first stage by stage to explain you the problem. My subject is today is monomeric C-reactive protein. Everyone knows about C-reactive proteins and anti-inflammatory which secreted from liver and. We are talking about the accumulation of this C-reactive protein which can be accumulated in monomeric as one of C-reactive protein. Second, let us go. We will go back about that. This group of research is not me. And if you want to do a successful research, you have to have corporations, you have to go for funding, you have to have big corporations. I get this corporation, we will explain to him in the future, after that, about the role of each person in my research. As I mentioned, the monomeric C-reactive protein is a structure of the C-reactive protein when they are participating, because the accumulated of this is the problem which is make the patients as Alzheimer. We will explain how this sequences is coming to be this. As we know, every stroke patients, 40% of them after they got stroke, they become to be Alzheimer diseases as a patient. We ask ourselves, what is this? What is the problem? We found the answer for that question because the monomeric C-reactive protein is accumulated in the nerves. We need the result for my talk. First, we cannot bring person and tell him, please give me a piece of your brain and I want to think about it. You cannot do this. You have to obtain from dead person who got Alzheimer's diseases, which in tissue bank. We get approval from Preston, UK. We get the brain sample. We pull up different criteria. I don't want to waste my time. Male, female, age, how many patients we are moving, and we're struggling to get this very human sample, to stain them, to identify the accumulated of C-reactive protein in the brain. How can we do this? First, by the way, this work is done from my professor Marcus Levin Corporation from Manchester University, which we got the sample from the dead people in Preston Tissue Bank. طيب. Now we need to see the localization of precipitation of monomeric C-reactive protein in the tissue. We are now in the stage of problem only. We stain them after that to see the two part, beta amyloid and B2. This is the localization where the monomeric C-reactive protein is precipitating in the nerves or in the brain side, and we stain them. We got first by doing immunohistochemistry after we make another work. Antibody, we design it to see the accumulation, which is M8C10. This is another group who make this antibody for localizing the precipitation of monomeric C-reactive. First single stain means first position. Monomeric C-reactive is stained in the brain side, as we saw. We identify that. Second, go for double stain by immuno. You have to see the side and the localized. Means where's the precipitation and where's the localization. We have to do it by double stain. First, the MCR is blue back, and see the surrounding here. To see, this is the accumulated. This is the amyloid. That means they are accumulated in the side, which is causing the neurotransmissions to move low, which is the reason of making Alzheimer's disease. We are in the stage of localization, still in processing. Right. Doing another stain from the human, the other is B2, the other localization, to find out there is also localized the monomeric C-reactive protein is accumulated. Double confirming. You have to confirm, and you have to double confirm that this is in brain human post-memoriam death people. We'll go for another test later on for human and animal. Also here, double stain for immunohisto to see localization of B amyloid and B2 in gray matters. There's to see where's the accumulated side from the brain also. Hala. This is going back. Okay. This is the double stain from infracted area of B2 red, which is a localization of the precipitation of monomeric C-reactive protein. Let us move. The result is we confirm there is accumulation by histological from post-memoriam side. This is the stage 1. Stage 2, we need to find out this is true or not true in vivo. That means we have to express our result in vivo in animal. We brought 14 mice. We inject them in hypochemical region. We make him to get a stroke. Then we treat him with plasminogen tissue activators. We leave him 1 month. Before that, we have 2 tests. The test one is to see this mice before he got Alzheimer and how we get Alzheimer as physiological test in water maze test. Means we put him in this water, he has to find the channel. Anyone he has a problem, he will find the channel to go through. The first test, see the mice, how he is moving. Second, after 1 month, how his behavior after he got stroke and he is accumulated the monomeric C-reactive protein in the face. Please, can you start the first one? See the mice? We put him in water. He will find the channel. He knows. He does not have Alzheimer. Okay? He goes. After 1 month, after we inject him with hypochemical and then he got stroke, see, he is looking for the channel he cannot find. Maybe he got, I don't know. How can we confirm? He cannot go the channel. We sacrifice them to see if this is true or not. We sacrifice him, we get histological tissue from his brain. See, we find the same antibody, we find them in histological from the mice, the accumulation of C-reactive protein. In double stain, in immunofluorescence, with different type of stain. That means our result is confirmed. We published this result in Q1 in Nature. I will show you the paper. Now we move to first stage. We identify the problem that this accumulation is causing the Alzheimer's disease in histological, in dead person, in mice, with histological side. After that, we need to know also in the hemorrhage, and we already stain them and we find the accumulation. We identify the problem, we confirm the result, we publish the result, 3 paper in high impact factor, I will show you. Now we need to know what can we do. This is the second stage of our research. Also, by the way, this all work is being done by funded from the stroke chair in Majma University. After we do this, we go to another group, another research now, to knock down the precipitation of P-amyloid and B2 to avoid the accumulation of monomeric C-reactive protein, to avoid him to get Alzheimer. Means we need to stop the accumulation, which we confirm, to stop the Alzheimer disease, and our patent on the preventing medicine in the Alzheimer disease after they got stroke, not treatment, preventing. Because if they got Alzheimer, they got Alzheimer. Now we're getting preventing. After they get the disease, after they got stroke, we have to design antibody to stop and knocking down the precipitation of monomeric C-reactive protein. Stage 1, we are working and we get patent on that. I will explain to you the patents and the way of patent. Now, processing, we are also dissolving the monomeric C-reactive protein in another patent with different antibodies. But I'm talking now about knocking down the precipitation, which we got the patent. Another future, I will explain to you in that one. Another group in America with Peter, I designed the antibody, which we make them in heavy chain, and this work is being done by cooperating with American people. I will explain to him and I will thank him in USA. We designed the antibody. After that, we try to do the region where they attached in P amyloid site. This is another project. We published two papers on that site. After that, we making the antibody to be injected as therapeutical antibody in mice to avoid the precipitation of monomeric C-reactive protein. We optimization the protein. After that, we inject this antibody with the mice who got Alzheimer's disease, and we try to see the result. The proof of the result also, they decrease the precipitation of monomeric C-reactive protein for the mice, and we do histological study also for improving the staining after that. We already published many results, more than 17 papers through the accumulation, through the antibody, through the treatment, through the therapeutical with high impact factor paper. Also, we patent this and we get the patent from King Abdulaziz patent. Also, we apply for prizes, we get money prizes.
Doctor, 5 minutes left.
What?
5 minutes left.
5 minutes? Okay. We already have prizes and applying for the this patent. We get the first one. Now we're going for future work. Future work, we need to confirm the monomeric C-reactive protein. How can we dissolve it? Means we need to inject another medicine to avoid the accumulation before it happens. The medicine for first one is for stopping the accumulated. The second is dissolving the monomeric C-reactive protein before they dissolve. As we say, we need to know about the good things in monomeric C-reactive protein. First, we need to know the structure of monomeric C-reactive protein. Third, we need to have antibodies which is attached in the membranal and then start dissolving the monomeric C-reactive protein. As I say to you, this work is being done with a huge work with a group in Manchester, in USA, in Saudi Arabia, and all this being funded from stroke chair from Majma University. Also, we have two students who is involving in the future for research, and that's it for today. Thank you.
Thank you, Doctor, for the informative presentation. And we would like to welcoming our second speaker, Dr. Mubashir Ali Dr. Mshari, he is Assistant Professor of Diagnostic Radiology at Majma University, Consultant in Neuro Interventional Radiology. Welcome, Dr. Ali. Mshari, عفوا.
السلام عليكم. Good morning, everyone. It's my pleasure to be here today, and I'm glad back again here in our university, and I hope that I will be giving you a very valuable lecture and to be useful and interesting one. I know maybe you are exhausted at the end of the day, but I hope to be interesting lecture. As I will be highlighted today, my talk mainly from our perspective in the stroke as a neurointerventionist, as well as I think from all from our community. Unfortunately, that the awareness of the stroke, especially at the early hours, compared to the heart attack or myocardial infarction, is far away less, unfortunately. So I will be highlighted, I think, both of those points, and I will go through my lecture. At the end, I will be happy to receive any question. My objective, I will be talking about definition of a stroke as well as classification and our role as interventionists, when to go, when not to go for thrombectomy. So as we know that, what is the stroke at the beginning? Stroke is a kind of brain tissue infarction. It's caused by blockage of the arterial supply. So, but we have two types of stroke. The most commonly that we are seeing the patient with a ischemic stroke. Unfortunately, those with the hemorrhagic stroke, which about 15 to 20% of the stroke, we do not have a rule as interventionists to go through and remove the clot. As we know that the global burden of the stroke, it's the first leading cause of the adult disability, as well as leading cause of the death, as well as about 6 million stroke in each year, and more than 15 million of the fatal stroke each year. So this is just to highlight and to show you how does it look like the ischemic stroke, which is the most commonly that we are seeing the patient with ischemic stroke, and those patients with the specific criteria that we can go through and remove the clot, about 85%. This is how does it look like. It's simple. Like we have an artery, as we can see here. This is in the middle cerebral artery. So whenever there is a blockage, it means that the distal area that's supplying this artery, supplying this part of the tissue, with the time will be dead tissue. So either we have a dead tissue and we have a salvageable, which is not yet dead tissue, that we can save it. This is our rule. So this is again. This is back again. This is blood clot, and this is, we call it an ischemic stroke, which is about 80 to 85%. And the hemorrhagic stroke, unfortunately, those we cannot intervene as interventionists, which about 15 to 20%. So this is again, how does it look like in the CT scan as from our perspective? So as we know that the patient, once is arriving to the emergency department, how the patient will be received by the emergency physician, then the stroke code will be announced. After that, I will talk about it briefly, but at some point, eventually we will do as a part of the workup CT, CTA, and CT perfusion if it is available. So this is the CT minus CT plane. This is how does it look like. So this is a CT. This is, as we can see here, there is a large hypodensity area. So this is abnormal. This is a part of the stroke. So this is most likely, it's a bit late. As we can see here, there's a mass effect and stuff like that. I will not take time on that. This is the hemorrhagic stroke. How does it look like? So we can see here there's a hyperdensity area that's involving the same area of infarction. Those patients, unfortunately, we cannot intervene as interventionists. So this is just to highlight when to intervene and what is our target if we intervene. As we know that from the knowledge that whenever there's a dead tissue in the brain, it cannot be retrieved, it cannot be reversed. But our target, not the dead tissue, the penumbra tissue, the salvageable tissue, which is seen around. So as we can see here, so this is the tiny black spot. This is, as we can assume, this is a dead tissue which cannot be reversed. This is not our target. So our target is the large area that's seen around, which is the salvageable. It can be saved, it can be reversed. So this is This is our target, that we go in and we save that area. As we can see here, it backs to normal whenever to retrieve the clot. So, so this is just as we know that an interrupted lost about 1 billion neuron every minute. So always time, as we know, time is gold in the brain. So I mentioned that at the beginning, how is our role as all of us in the medical field, what is our role to educate the people about the stroke symptoms? And I will be going through this. So this is at the beginning. So at the beginning, whenever there is any stroke, like at your home, whenever the patient is, whenever you're one of the relative or someone, you just see in front of the anywhere, like the patient. The first thing that we have to be aware and educate the people or general public how to recognize the stroke. After that, immediately calling to the emergency department, and emergency department as well has to be in prompt evaluation to take the patient from the site and then to go to the stroke unit to the emergency department. This is how the workup and how is the pathway for the stroke patient. So this is, I think, this is one of the very important slide. So as I mentioned, the first, we have to educate the people. We have to increase the awareness of the stroke. If you just ask any of your relative or any of your close friend, what is the symptoms of the myocardial infarction or heart attack, I think most of the people, they know how the chest pain, it's like knife pain, it's like shortness of breath. But if you ask them specifically what are the symptoms of the stroke, it might be not easy question to tell. So they might be a vague answers. But I think we have to delineate, we have to dig more on that point, we have to educate all our relatives, because why I'm just pushing on that point. Unfortunately, most of the patients that we have received, they are out of the window. So whenever they're out of the window, so you just will be disappointed that nothing to be done with the patient. The patient will be unfortunately disabled for the rest of his life or rest of her life. So what are the symptoms that might be presented for the patient in the stroke? So we can call it as a phase. So first, you might have only the face drop. You might have as well A from the arm weakness, S from the speech difficulty or slurred speech, and T immediately time to call emergency. But I think this is most probably for the anterior circulation stroke. For the posterior circulation stroke, unfortunately, there is most of the time they are vague symptoms. But how to pick up? So whenever all the time, whenever I face some people close around me and I have to educate them, it's not only this the face. So whenever you have a patient, an old patient, have a comorbidities, hypertension, diabetes, obesity, old age, if they have something unusual presentation, a severe headache, patient fall down with no any reason, you have to raise a possibility there might be a stroke. Not specifically for anterior circulation, might be a posterior circulation. So that's why posterior circulation, most of the time, patient will come very, very late out of the window. We do nothing for them, unfortunately. So whenever you have a patient, close friend, anyone, old age, have multiple comorbidities, vague symptoms, they are not explained by anything, immediately patient must go to the emergency department, CT scan must be done. If you have no CT scan seen around, go around hospital to be done. So this is the symptoms. So this is the NIH score. It's a score that measured by our close friend from the neurology. It's a systemic assessment tool, predictive lesion size and measure of the severity, predicted of the short and long-term outcome. It is designed to be simple, valid, and reliable tool that can be administered at the bedside. The NIH score must be assessed before any patient, before any emergency physician or a neurologist contact us as a neurointerventionist, because based on the NIH score that we can say the patient is disabled or not disabled. So from here, this is there is an online site, because it has a 42 points, not easy to assess for each patient. So most of the time they open up through the website and then make all the 42 to tick all of them, whether the patient have this symptom or not. After that, they contact us and they say the NIH score is like that. So if there is an NIH score is more than 50, more than 25, It's very neurological impairment. 15 to 24, severe impairment. 5 to 14 is moderate. Less than 5, it's mild impairment. So as our rule, more than 5, those from 5 to 25 up to 41, this is indicated for thrombectomy if the patient is having large vessel occlusion. I will show that. I will show you that. But those patients.
5 minutes left.
Okay, I will go very quick. If it is less than 5, will be mild impairment. Those as not disabling, so we might not intervene. So this is a website for the NHS. So I will go through. So aspect score is very an easy score that will be assessed by radiologists if they don't have a software called CT perfusion. So I will skip this. Modified ranking score is a score that measure and assess the disability and the function of the patient. So those patients having more than 3, as the patient cannot walk or bed-bound, so most of the time we do not intervene because there might be risk more than the benefit of the patient. So this is, I think I will skip this. Okay, so this is the mechanical thrombectomy. It's a new trend, it's a new approach. The question is, all the patient can go to the mechanical thrombectomy with stroke? Is not. The answer will be not. So when to go for the mechanical thrombectomy? So it has to be the first of all, large vessel occlusion. We have to make means middle cerebral artery, anterior cerebral artery, or the basilar artery. Just distal to that, it's not an indication for this time being, as a guideline, not indication for mechanical thrombectomy. And at the same time, maybe TPA, whenever we go distal to the middle cerebral or anterior cerebral artery or basilar artery, the IV, the TPA is most of the time is better. And is there any contraindication that we can start the TPA for those patients and bridging to the mechanical thrombectomy? It can be done, and most of the time we do that. So this is very quick. So this is CT scan, patient presented with a stroke, MCA syndrome. CT angio as a part of the workup. We can see here, so there is here, the middle cerebral artery is okay here, but here is nothing, right? So there is a block. So we cannot see the left middle cerebral artery. So this is the angio. When I got in, we can see that there is complete block, right? So I go through from the femoral artery most of the time. Sometimes we can go through the radial artery, and then I retrieve the clot by the stent. So again, this is another patient, but I read it without stent, very easy to aspirate. So this is the mechanical thrombectomy, how is the setup in our angio suite. I think I will not take time on that because something important. Yeah, so this is the pathway. I think it's much important. The pathway, how the patient will be received from the emergency department and contacting as a neurointerventionist. But I will skip. So here, so there's all the patient. Whenever the patient is suspected for a stroke, from our hospital, currently I'm working in King Saud Medical City. So our stroke window will be 4.5 hours. So whenever the patient is within this window, will be activate the code stroke by the emergency department. So after that, patient will be going into the critical area. So all the routine workup will be done. ABC, NHS core, as we mentioned, vital signs, creatinine, as well as it has to be CT part of the protocol. CT, including, as I mentioned, CT minus CT angio to see the blood, all the blood supply, as well as CT perfusion if it is available. So after that, as from the radiologist will be reading the CT, as well as at the same time the neurologist will be involved to see if it is the patient is indicated for the TPA or not. So based on that, as mentioned, aspect score, it has to be assessed, and then after that, patient is the patient indicated for the IV TPA or not? Based on the patient is having, as we mentioned, is it large vessel occlusion, middle vessel occlusion, as well as the patient having a hemorrhage or he doesn't have any hemorrhage. So those are criteria to indicate whether the IV is indicated for such patient or not. So after that, return the patient to the emergency department to complete management. If the hemorrhage is identified, so as we know that the IV TPA as well as the thrombectomy is not indicated, patient will go to the another pathway. So if the patient is indicated for the IV TPA, they will start to the IV TPA. At the same time, as interventionist, us will be a consultant consulted to see. So present of the IVTPA, if the patient already started the infusion of the IVTPA, does not mean the patient contraindicated for the IV thrombectomy. So we can see the patient if the patient has, because most of the time, if the large vessel occlusion, even the TPA, it will not work most of the time. So thrombectomy always is the best choice for the large vessel occlusion. So whenever it's distal, so the IVTPA most of the time is better. So as we can see here, so the LVO, as I mentioned, is large vessel occlusion identified. So immediately patient should be transferred to the angio suite. And most of the time, as from our center, from the patient at the door time until the puncture site at the angio suite, most of the time we do not exceed 40 minutes. So as I mentioned at the beginning, each 1 minute there is 1,200,000 urine lost in each minute. And thank you so much for listening.
Thank you so much, Dr. Al-Ali. Before we start to open the floor for the audience for question, I just to ask Dr. Al-Baradi one question. Doctor, you talk about supporting scientific research to supporting stroke patient. So what do you think, what is our capability in our university to establishing a medical unit for treating and rehabilitating stroke patient?
طبعا أشكرك على السؤال هذا اللي أنا تكلمت مع سعادة الوكيل بخصوص إنشاء بالتوصيات. إحنا حلمنا كان في كرسي الشيخ عبد الله بن عبد المحسن التواجري إنشاء وحدة تشخيصية تأهيلية. طبعا إحنا نجحنا في عمل أبحاث، نجحنا في عمل ابتكارات، نجحنا في عمل براءات اختراع، تحقيق جوائز، لكن الآن إحنا ما زلنا نتواصل مع وزارة الصحة لإنشاء أول وحدة على الأقل مش تشخيصية تأهيلية لمنطقة سدير. طبعا في الإخوان قالوا إنه في 40 وحدة في الباحة، في الطائف، في كل مكان. إحنا حلمنا أن ننشئ وحدة تشخيصية تدريبية أو تأهيلية لمرضى الجلطات الدماغية، وهذا طبعا يعني بإذن الله حيخرج فيه توصيات بإذن الله في هذا المؤتمر في جامعة المجمعة لعمل وحدة مختصة لمنطقة سدير. يعني ما قلنا في جلاجل ولا في خلينا في المجمعة بس، لأنه أنت عارف لما يحدث الجلطة 5 ساعات ممكن الإنسان يتداركها في هذه الوحدة التشخيصية.
الله يعطيك العافية. Thank you so much, Doctor. Now we will open the floor for the audience to ask any question. There is any question for our speaker?
Thank you both, Doctor, for great presentation and very informative session. My question is for Dr. Raed. So you showed at the beginning of your presentation that you were able to detect CPR in both A beta and tau in AD patients. So have this molecule been detected in other type of dementia, like chronic traumatic encephalopathy, for example, or any type of dementia where both these two pathology of A beta and tau are found? Do you have any knowledge about that? This is general question, and I have another experimental one.
يلا. تفضل السؤال الثاني.
Okay.
تبغى تسألي ولا أجاوب أنا أول؟
لا, we'll wait for your answer and then I'll ask the second one.
طبعا طبقنا أول we tried in human in dead people first. As I told you, we get the sample to identify the localization of the patients from post-mammalian patients. After that, we do it in mice. And we already sacrifice, and also we do. To do to human is another story. Is something you have to have donation from the people who wants to get sample. We don't reach this point. We reach point only in mice, and we localize it in P amyloid and T, as I show you the result. But for human, is different story, and for pharmaceutical is another story to industrial. I told you, I cannot do producing the medicine yet. We have to try it in human, And also the advice to me in Visor, he said to me, make it as diagnostic test only. Second question.
Any question? Thank you so much, Dr. Mshari and Dr. Rad. There is any question? Oh, sorry.
تفضلي.
تفضلي دكتورة.
تفضلي دكتورة.
It's working now. So my second question is for the animal models that you used in this experiment. So again, with the A beta pathology and tau, are they naturally appearing in those mice models, or is it you perform a stroke on Alzheimer models? Like, are these different? Because we know.
No. You're mixing. We brought the mice.
Yeah.
And we producing, as I told you, we inject him in hypochimal.
Yes.
And then we got the Alzheimer. We got stroke for them, and then we treat him and we let him. There are 14 mice.
Yeah.
6 of them died, and 8
Yes,
of them
doctor.
still.
But I'm asking about the mice themselves. Are they just normal mice that you do stroke to them and they have these pathology? Yeah,
Yes.
that's what I'm asking.
And what test I show in water rays is they are normal and they behave to find the channel before they got any problem. After that, we make them, as I told you, they are 14, 6 of them died. And when they died, I make big ceremony for them because we lost the result. 8 of them, we got the result. 3 of them sacrificed, and we do the staining to confirm. 3 of them, we inject him with antibodies, what we are producing, which to see the effect for anti-precipitating of the C-reactive. 2 of them also died after the treatment of the antibodies. That's the story for animal models. Yes. تفضلي.
Here, please.
I want to explain. This work is not done by me, by the way. I have to explain that they have Professor Marcus Levin, Peter from USA. I'm explaining to you the summarizing of the project. My part is in histological section and antibodies. This is my part. But I'm explaining you the result. I'm telling you this truth. My specialized in histology side for immunohistochemistry, but other part knocking down, producing antibodies, animal model has been shared because I got some histological section. That's to be fair. Second question.
Yes. Assalamu alaikum. This is Dr. Lina Al-Bloui, endocrinologist and the faculty in internal medicine at Majma'ah University. My question is actually for Dr. Mshari, if you allow me. Yes, please. I'm a clinician, that's why I focus on. So in regards to patients, stroke patients, that you mentioned that even if they took or receive TPA, they still can undergo thrombectomy. Is that right? Is there any limitation or exceptions for that rule?
To be honest, no, because as I mentioned at the beginning, for rule of the thrombectomy, first of all, it has to be a large vessel occlusion. So the literature and the study shows that the IV TPA, even if it is infused, because as you know that not the angio suite as well as the stroke as a thrombectomy is not a service available everywhere. So the real things and the real world that most of the patient that might be transferred from around small hospital. So to save the time, because there is no, I would say the guideline shows up to 24 hours that we can intervene as a neurointerventionist, but based on the finding with the CT perfusion, as I mentioned, there is a criteria. So, but if the patient, let's say, is away from the hospital, and we know that the CT angio shows there is a large vessel occlusion, it's not okay to just wait the patient for like a couple of hours to just arrive to your hospital. So the IV TPA, it might work, but most of the time, if there is a large vessel occlusion, it will be not a definite treatment. So, but we can start them. Sometimes, whenever they arrive and we are going for the intervention, and I just do an angio, it might be go away. with the IV TPA, but still it's not an option. But we do most of the time, we do bridging if the patient is away. But if there is a tertiary hospital and you is there, large vessel occlusion, most of the time, from the door to the puncture time, we are not exceeding 40 minutes. So most of the time, the IV TPA will be not given. Yeah, thank you.
We'll take the last question. Okay, thank you so much for our speaker, Dr. Al-Ali and Dr. Al-Baradi. Thank you so much.
أنا ودي أشكر الدكتور محمد الشهري على حضوره، وإن شاء الله بإذن الله تعالى إحنا في عندنا strategical plan for industrial for our patent in future إن شاء الله بإذن الله تعالى.
الآن في جوائز للحضور من جامعة المجمعة، راح يتم الاختيار عن طريق الكاميرا. طبعا الفائز الأول كانت موجودة في الصورة، الآن الثاني. الفائز الثاني الفائز الثالث فائز الرابع. Now we would like to welcoming Dr. Ahmed Al-Sahili from Jazan University. He will present a scientific paper. Welcome, Dr. Ahmed.
السلام عليكم ورحمة الله وبركاته. في البداية حاب أشكر جامعة المجمعة الحقيقة على حسن التنظيم وكرم الضيافة. جزاكم الله خير وكثر الله خيركم. I'll be talking about self-management intervention to improve mobility after stroke, as it has been a concern for rehabilitation practitioner that a lot of patients after leaving acute care and leaving hospitals, they cannot have enough amount of therapy in formal facilities. So this is one of the initiatives actually to increase the amount of care and therapy they can do on their own at home or in the community. So in a few minutes, I'll be talking about rationale for conducting this piece of research, and then the methodology that was taken, and then I will discuss our findings, and then there will be time for discussion and questions. As a lot of our doctors, speakers, and thank you for them, they have addressed the mortality and morbidity for stroke from clinical perspective. From rehabilitation, I'll just focus on mobility impairments after stroke as example for one of the most problems and common problems after stroke. Mobility can affect more than 50% of stroke survivors, unfortunately, and will affect their quality of life and performing their daily activities. And so there is a need for a proper rehabilitation for this population. In stroke rehabilitation, it has been evident that higher intensity of therapy can lead to better outcome. But unfortunately, evaluation of current practice worldwide, even in the high-income countries and middle-income countries, it's only It's only a low intensity of therapy that has been delivered and that actually affect people after their stroke. 45% of them, they might feel unsupported when leaving hospitals. The situation was even worse during the COVID time when the therapy and rehabilitation services were completely stopped at some point of time. And so self-management intervention can help to increase the amount of therapy they are receiving and to keep them active at home or in the community. Self-management programs provide stroke survivors with knowledge, actions, and confidence to take or manage their medical and emotional role at home, either to maintain or create a new role of life after stroke based on what impairments they got after stroke. A lot of literature review showed that self-management have potential to improve functional ability, participation, self-efficacy, quality of life, and psychological well-being for stroke survivors. However, there's still a need for more exploration of most effective self-management intervention that can be used for stroke survivors. And so hence it came for our review. The objective for our review was to review the evidence around self-management intervention that can be used for stroke survivors, especially to improve their mobility. We have used an integrative review design, which allow us to include quantitative, qualitative, and mixed methods studies in the review. And we registered the study on Prospero, and we are kind of used a very wide inclusion criteria for selected study to capture as much as we can of studies that discuss the topic of the review. We searched 8 electronic databases. The search was done from 1992 to 2021, and screening was done on multiple levels for inclusion of eligible studies. For quality assessment of studies, we use different methods based on research design for every selected research article. And then we used the grade framework to assess the quality of evidence within those studies. And then for data synthesis, we did a quantitatively led narrative synthesis of data that was supported with qualitative data when possible. For findings, we actually selected eventually 24 studies after screening of around 2,000 studies. And it was not surprising because stroke and stroke rehabilitation is a big topic, and there is a rich literature on that. And for study characteristics, we got different study designs, including RCTs, case report, mixed methods, cohort studies, and other study designs. And they were published in 10 different countries around the world. The total number of participants in those studies was 823 participants with mean age of 63.7 years. And the main eligibility criteria for these participants was having a mild to moderate impairments after stroke.
Sorry, Dr. Ahmed, 2 minutes left.
Wow. Okay. So for the conceptualization of self-management, we found that self-management was conceptualized differently by different people, stakeholders in stroke rehabilitation, including patient therapists and care providers and policymakers. And then the most used self-management strategies were patient education, goal setting, problem solving, action planning, self-monitoring and feedback, and social support. And all of these programs were integrated to formal therapy session, and they were not a therapeutic plan on their own. This is one of the important findings. We found a significant improvement in some studies for functional mobility, walking speed, walking distance, and number of steps per day, and walking time, leg impairments, and lower body strength. Other secondary outcomes, we found some significant improvement in self-efficacy, quality of life, activity of daily living, patient anxiety and caregiver depression, pain, fatigue, mood, cognition, and stroke knowledge. 4 qualitative findings were driven from our data. First one, the perception of the participants of feeling self-management as valuable addition to the therapy, and their perception of improvement in their mobility, and increasing knowledge about stroke, and their desirability to continue therapy after finishing the self-management program. Here, what we get using grade system for grading of the evidence within studies. Overall, we found self-management interventions feasible, safe, and acceptable by participants, and appreciated by patients and their caregiver. And all participants who showed improvement had limited to moderate impairments. Some technologies such as telerehabilitation, smartphones, video conferencing, online resources were good and useful tools to support for delivery of self-management. I'll skip this. I'll go to the take-home message here. we found some evidence for functional walking, mobility and walking improvement using self-management intervention. However, there is consideration that self-management intervention are not one size that fit for everybody, and a specific consideration should be taken to assess the functional ability stage of recovery, comorbidities, and goals of rehabilitation for this population. The last thing here is that self-management is not suitable for everyone. As I discussed before, most common population who are fit and can use the self-management are the people with mild to moderate impairments after stroke, and people who are motivated. So motivation and readiness of patients to take that role is a key for success of any self-management. It's time for discussion. Thank you for listening.
Thank you.
And thank you for
so
having
much,
me.
Dr. Ahmed. Thank you. Have a seat, Doctor, please. Any question to Dr. Ahmed? No question? Okay, thank you so much, Dr. Ahmed. Thank you. So we're concluding our session. Thank you for listening.
شكراً دكتور وداد العنزي. وبهذه الجلسة تنتهي الجلسات العلمية للمؤتمر، وننتقل لإعلان نتائج الفائزين على أفضل ملصق علمي. So winners of Best Poster Award. لذلك يتفضل سعادة الوكيل بروفيسور محمد الشهري لتسليم الجوائز، ودكتور سحر الدوسري لإعلان الفائزين.
بسم الله الرحمن الرحيم. الفائز في المنافسة الملصقات العلمية بالمركز الثالث دكتور ساغانتا, isn't it? His poster, it's titled by a neurosurative effect of المجمعة بين in rat model of stroke. Congratulations. الفائز بالمركز الثاني في منافسة الملصقات العلمية دكتور سارة بجعيفر. His poster titled My Maximum Tolerable Daily Dose of Mirror Movement Therapy Ankle Exercise After Stroke and Early Phase Dose Screening Study. دكتور سارة. الفائز بالمركز الأول الطالبة غالية دويش. Poster Stroke Detection Using Advanced Machine Learning Algorithm. ألف مبروك الفائزين.
فليتفضل المحكمين لمسابقة الملصقات العلمية لأخذ صورة تذكارية مع سعادة الوكيل. أعضاء اللجنة العلمية تفضلوا مشكورين. لأخذ صورة تذكارية مع سعادة الوكيل. People who evaluate the posters, please join us to take a memorable picture with the dean. Thank you, Doctor. والآن لإنهاء المؤتمر والتوصيات المستخرجة من المؤتمر يتفضل الدكتور عبد الرحمن الحربي عميد كلية الطب لإعطاء التوصيات.
السلام عليكم ورحمة الله وبركاته. توصيات مؤتمر جامعة المجمعة للسكتة الدماغية. خلص المؤتمر إلى عدة توصيات منبثقة عن المناقشات حول السكتة الدماغية خلال يومي المؤتمر. التوصية الأولى: يدعو المؤتمر إلى اتباع أساليب علاج الجلطات الدماغية من تدخل علاجي أو تدخل عن طريق القسطرة أو الأشعة التداخلية حسب الأدلة العلمية الحديثة والمتبعة في المجلات العلمية المحكمة. التوصية الثانية: يؤكد المؤتمر على الدور الحيوي على جميع الفرق الطبية من أطباء وأطباء أسنان ومتخصصين في العلوم الطبية وكادر طبي تمريضي، وكذلك من كادر متخصص في التأهيل الطبي والتغذية، وكذلك من جميع التخصصات الطبية اللي لها دور من فرق الطبية المتخصصة في الجلطات الدماغية، ومن ضمنهم كذلك الفرق الإسعافية في الوقاية من السكتة الدماغية من خلال تقييم المخاطر والفحوصات المتخصصة لمرضى السكتة الدماغية. التوصية الثالثة: يؤكد المؤتمر على أهمية الوعي بمخاطر السكتات الدماغية والعمل على رفع الثقافة الصحية للمجتمع لما فيه ارتقاء من صحة الفرد والمجتمع. التوصية الرابعة: يوصي المؤتمر بدور الجامعات للعمل على المزيد من الأبحاث الطبية في مجال السكتة الدماغية، وذلك بالتعاون مع المراكز البحثية والكليات الطبية المتخصصة. التوصية الخامسة: التعاون بين جامعة المجمعة ووزارة الصحة والمؤسسات التخصصية التعليمية للتعاون على التعاون لتطوير طرق العلاج الطبي والبحثي والدعم بالكوادر الطبية التخصصية من جامعة المجمعة. التوصية السادسة: بناء على ما اتفق عليه من الزملاء المشاركين في المؤتمر، استمرار مؤتمر الجامعة المجمعة للسكتة الدماغية سنويا على أن يحدد في تاريخ معين سنويا في تقديم أحدث السبل الطبية والبحثية في مجال السكتة الدماغية. وشكرا لكم.
وبانتهاء التوصيات ينتهي مؤتمر السكتة الدماغية القائم على مدى يومين، وشكرا لكم لحضوركم واستماعكم. We'll see you next year. Thank you.